Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, everyone. This is Wayne Callan for Attitude Magazine. Glad you can be with us. Today's topic, ADHD over 50, is one that many of us, those with ADHD and clinicians who treat them, have little solid information about. We do know that ADHD is highly hereditary, so that those who were never diagnosed with it in their younger years are most likely still struggling with it in their 50s, 60s, and 70s. The fact is that few studies have been done on the topic. Although it is important to note, I wanted to say here that Kathleen Nadeau, founder of the Chesapeake ADHD Center of Maryland, is conducting research right now. She has launched a project to individually interview older adults with ADHD. She's currently looking to interview men with ADHD who would like to participate in the research. You can contact her at drkathleennadeau@gmail. That's drkathleennadeau@gmail.com. The point is that doctors and patients are not thinking of ADHD as a characteristic of somebody who is 50 and over. So the condition may be overlooked in the 60-year-old who has trouble staying engaged at home or even at work, despite a lifelong history of inattention. The good news is that many over 50 can be treated and their symptoms managed. What makes the diagnosis more complicated is that many in their 50s and beyond are experiencing mental changes due to age and perhaps symptoms of dementia. According to today's expert, Dr. David Goodman, this is where it gets difficult in aging patients. One has to distinguish between longitudinal ADHD symptoms and the overlap of age-related decline. You can have both simultaneously. We are pleased to have Dr. Goodman with us today to give us the reference points and research about how those over 50 and beyond can get an accurate diagnosis and the most effective treatment. Dr. Goodman is an assistant professor of psychiatry and behavioral sciences at the Johns Hopkins School of Medicine and an internationally recognized expert on ADHD in adults. He has been a principal investigator for ADHD clinical trials, authored 30-plus peer-reviewed scientific publications, and presented over 600 lectures to clinicians. You can reach him at addadult.com. I'll turn it over to Dr. Goodman now. David, it's great to have you here today.
Thanks, Wayne, and thanks for inviting me to do this program. I appreciate everybody who's on the call today. If you are, you will probably learn more about adult ADHD than most of your colleagues. The fact is that very few people are formally trained on adults and ADHD, and the literature is only developed over the last 10 years. I'm actually the lead author on the first literature review of ADHD in older adults that's been published internationally. So this is my favorite picture of adults with ADHD. Okay, get on the bike and ride off into the sunset. That would reflect a certain degree of impulsivity, but also a certain degree of fun-loving nature. So why is it important to look at ADHD in older adults? Well, we do know that ADHD continues into adulthood. There are several long-term studies with children. The longest prospective long-term studies, 33 years. That's an amazing follow-up for tracking a disorder over the course of time. There's very little information on ADHD in adults over the age of 50, and I'll show you some of the literature that exists. When we ran clinical trials of medications for ADHD, the cutoffs in the research protocol was 65. So if you were over 65, you cannot be entered into an ADHD drug clinical trial. So we don't have a lot of research information on these folks. And also, if you are over the age of 60 and you have ADHD, the likelihood that you were diagnosed in childhood is almost 0%, because 50 years ago, people were looking at ADHD much more focused on the disruptive behavior, not the inattentive and disorganized behavior. We now come to appreciate that although the disruptive hyperactive disorder behavior in children gets the boys identified, as all of these children age, it becomes the inattention and the disorganization that causes impairments. And we also have an aging population. So if these folks have ADHD and clinicians aren't trained, they're going to make the spurious presumption that any cognitive complaints are a function of aging and miss the opportunity to make a diagnosis in a very treatable disorder. Why is adult ADHD so important in psychiatry and yet so under-recognized? And why do I say it's under-recognized? Because most psychiatric programs, even to date, only have one, maybe two lectures on adult ADHD, unless you're at a center that has a clinic specifically designated for adult ADHD. So if you look at the prevalence rate of major psychiatric conditions here in the U.S., about 1% schizophrenia, 2% bipolar disorder, 3% generalized anxiety disorder, 4.5% adult ADHD, and about 6 to 7% major depression. Adult ADHD is the second most prevalent psychiatric condition in the adult population, and yet clinicians and physicians are not trained to assess this. So how do we make a diagnosis? We still use the criteria out of the DSM-5. They were changed 3 years ago. So we moved the age from 7 up to 12 because most adults can't remember symptoms before age 7. And if we looked at patients with a diagnosis of symptoms before age 7 and before age 12, they actually turned out to be the same. You need to have the symptoms in several settings. You don't have ADHD because you sit down at dinner and don't listen to your spouse. You need to have these symptoms in multiple settings and have impairments, either noticed by other people or clearly noticed by yourself. And even though DSM-5 was specifically rewritten to include descriptors for adult ADHD, it did not consider how ADHD manifests itself in patients over the age of 60. So we still extrapolate from the inattention, the hyperactivity, and the impulsivity. So if you're familiar with ADHD, here are the 9 symptoms in the inattention: easily distracted, careless mistakes, difficulty sustaining attention, etc. The previous threshold was 6 symptoms out of 9, both for children and adults. DSM-5 changed that and lowered the symptom count threshold in adults to 5 of 9. You still need to have had symptoms as a child, and you track these symptoms over the course of time, which I'll show you in a simple case report of mine. In the hyperactivity, it's the same symptoms as you're familiar with: fidgety, inability to sit still, excessively moving, talks excessively, blurts out answers, etc. And again, it's 5 of 9. Now, having said all of this, simply doing a symptom checklist to make a diagnosis does not make the diagnosis. 1, because the patient can misinterpret the questions. 2, they can be faking ADHD in order to get stimulant medications. So the diagnostic criteria of symptoms is in the context of a clinical history, symptoms starting in childhood that remain chronic, relatively unchanged, and impairing over the course of time. The adult with ADHD will say, "I can't remember never being this way." If you interview an adult and say, "If I interviewed you 20 years ago, would you have been talking about these symptoms?" and they say no, then I don't know what they have, but they probably don't have ADHD. And that's a critical clinical question in your clinical interview. So conceptually, symptoms start in childhood. Impairments are clear, usually in boys versus girls with the impulsivity and the hyperactivity, although educators are much more familiar now to look for the inattention and the disorganization, and the diagnosis gets made in childhood. But if the child is smart, if they have compensatory skills or environmental structure by parents and teachers and schools, then the impairments may not be noticed until much later in life. And as you age, your responsibilities increase and the environmental supports diminish. That's when impairments become evident. So when you go from high school to college, you have to manage your time, plan, organize, anticipate. If you have your first job, you're reportable to your boss. You have to follow through consistently with what your job expects. When you get married, you have to negotiate. When you have children, you have to juggle your time much more effectively. If you get a promotion, you may move to a responsibility level that exceeds your ability to compensate. And so these are all of the elements that may lead somebody into a clinician's office in order to be assessed for ADHD. Conceptually, though, it's very important to keep in mind that ADHD is a clinical diagnosis. There are no brain scans, there are no psychological tests that will make this diagnosis in the absence of a comprehensive clinical interview. Again, I'm going to say the same thing over and over and over again, and that is childhood symptoms that evolve chronically and unchanging over the course of someone's life. This is in contrast, though, to intelligence, learning disabilities, and executive dysfunction. Executive dysfunction has to do with prioritization, organization, time management, and working memory, the ability to hold information in your head as you manipulate it. Those three circles then can be delineated on neuropsychological testing. But I don't routinely send somebody who I suspect has ADHD for neuropsychological tests to confirm it, because even though the test may come back positive, you need to interpret the results in the clinical context. The other is, even if the tests come back negative, it doesn't mean the person doesn't have ADHD. And we could spend a little time talking about why I take this position on neuropsychological testing. So what are the diagnostic considerations? You have a 55-year-old who comes in complaining about cognitive symptoms. What else do we need to look at? Well, anxiety, untreated depression can certainly cause alterations in cognitive ability. Substance abuse burns all kinds of holes in your brain that cause cognitive problems. There are medical illnesses, medications, over-the-counter supplements, all of which can impair concentration, focus, and sustained attention. Neurologic disorders, a history of repetitive concussive injury. So making the diagnosis of ADHD is very much a medical consideration, because you need to rule out anything else that might account for these cognitive changes. So what's the prevalence? I understand what adult ADHD is. Now, give me some idea of how prevalent it is in the general population. This is the first epidemiologic study out of Amsterdam. They looked at about 1,500 participants who were screened for ADHD. And then of those who screened, 231 were interviewed in a structured diagnostic interview. Now, they were using the old DSM-4 criteria, which is stricter, 6 out of 9 symptoms, either in inattention and or hyperactivity, impulsivity. They did rely on the respondents' recollection of childhood symptoms in order to make this diagnosis. And what did they find? If you look at full diagnostic DSM-4 criteria, that is childhood symptoms before the age of 7, the prevalence rate was 2.8%. If you just look at those adults who look like they have ADHD from their symptoms and impairments, but the symptom count wasn't 6 out of 9, but the level of impairment over the course of their life was clear and significant, then the prevalence rate rises to about 4%. Men and women reported similar symptoms of symptoms, and prevalence rates of subtypes were the same. Now, my mentor used to say, never let a speaker get away with making an important point based on one study. And so here's a second study. This is a German study looking at about 1,700 adults between the ages of 18 and 64. They did childhood screeners and adult symptom screeners. Of the 1,655 adults, about 400 were over the age of 55, and the prevalence rate there for ADHD was about 3.5%. So if you look at the previous numbers of 2.8, 4.2, and then 3.5, let's split the difference and say the prevalence rate of ADHD in patients over the age of 50 is about 3%. That's actually quite substantial. If you think about the 3% in light of the other major psychiatric disorders, it still is higher than bipolar disorder and schizophrenia, and almost equal to generalized anxiety disorder. So is anybody looking for this? Does anybody understand this? There's an interesting survey in the U.S. of 165 memory clinics across the country. The response rate here was about, of the 165, 62 sent back their questionnaires, and there were a number of questions they asked. The survey discovered that only 1 out of 5 clinics were actively screening for ADHD. About half reported seeing ADHD patients, and 60% reported contact with previously diagnosed ADHD. But if ADHD wasn't being assessed in the evaluation of cognitive complaints, it was not considered as a premorbid baseline cognitive function. That's to say that if someone comes in and you look at their symptoms as a cross-section in time, a point in time, and you have no history of their cognitive history, you're going to conclude that this is an age-related cognitive decline, shrug your shoulders, explain to the patient there's nothing we can do, and send them on their way. And if you miss ADHD, you miss the opportunity to treat a remarkably relatively easy cognitive disorder. So what's the patient's experience here? Let's dial all of this down into a case history, and this is one of my patients. So you can think about your own patients. You can think about yourself if you're an older adult listening to this. You can think about a parent of yours because you've been diagnosed with ADHD. You say, well, I always thought my mom had this because she showed up late at school and she always forgot to get the groceries and my laundry was never done on time. So this is a 62-year-old married white male who came to me complaining of depression because of increased difficulties during his job. And this is a common presentation for people with ADHD because if they're unable to perform at work and they run the risk of losing their job, they come in complaining about the reaction, anxiety and depression, to the environmental demands. They don't come in saying, I have ADHD. He's got a medical issue of elevated cholesterol, and his depressive symptoms are episodes of amotivation, flat mood, increased sleep, reduced energy, withdrawn, quiet, passive suicidal ideations, apathy, increased anxiety, but no agitation. And his episodes typically last days to week. Looks like another major depressive episode. And yet, his cognitive complaints, forgetful, frequently making lists, drifting off in conversation, trouble completing paperwork, difficulty sustaining attention, completing tasks, inefficient organization, procrastination, interrupting in conversations, and impatient. Well, if you're a mood disorders expert, you say, look, if the guy has a major depressive episode, all of these cognitive symptoms are a function of his major depressive episode. We don't need to go any further in making a very clear diagnosis of recurrent major depression. And then you say, okay, well, now that you've listened to this webinar, let's talk about childhood. Well, it turns out that he recalls as a child, he was easily bored. He was the class clown. He was fidgety. He had difficulty sustaining his attention when doing homework. He had to reread because his mind would wander. He had difficulty starting his homework. He often procrastinated. He was handing in his homework assignments late, and he was moody. He did deny being forgetful and misplacing things and said he was an A student. So let's track these symptoms into high school. In high school, again, he's inattentive and distractible in lectures, poor quality notes, noted by teachers for careless errors, was moved to the front of the class because he wasn't paying attention, difficulty finishing assignments on time, and daydreaming in class. Well, now this starts to look like ADHD, but if you hadn't asked, you'd never have seen it. And what happens in college? Well, his class attendance is good. He's not tardy, but again, difficulty finishing tasks, slower than other students on assignments, persistent difficulty listening in lectures and taking notes. And by the way, it took him 5 colleges to complete his undergraduate degree in computer science. So now that you have the history, you say, well, published in the Journal of Duh, he has ADHD and recurrent major depressive episodes. Let's take the family history. Interesting, 17-year-old daughter was diagnosed with ADHD at age 12. She also has a history of depressive episodes and treated on fluoxetine. And I might make note, her SAT total score was 2270 over 2400, clearly in the superior IQ range. And it should be noted that people who have higher IQs will often be missed for ADHD because their academic performance is satisfactory and they're not bothering anyone. IQ and ADHD, categorically independent concepts, and it doesn't matter what your IQ is, you can still have ADHD. He also has a brother, 55-year-old, who's been described historically as scattered, disorganized, and impulsive. Well, let's look at substance abuse because you're talking about an older person and maybe they're drinking too much or maybe they're getting high on marijuana too much. Coffee intake, 3 cups of coffee a day. Often I find in my adults with ADHD, they're self-medicating with caffeine. And he also has a couple of drinks at night. Not too concerning, no history of binge drinking. So what did we do for this gentleman? We put him on a long-acting amphetamine-based medication and titrated up to 60 milligrams in the morning with good response. 3 months later, however, even on the stimulant medication, he had a depressive episode. So bupropion XL was started and increased to 300 milligrams for the relapse of his depression. And the outcome, he has remained on these medications now for over 6 years, has had good mood stability without depressive episodes. He has good functioning at his job and holds a security clearance position in the government. So the outcome here has been very good, and it would not have been had the ADHD not been part of the treatment. So when you have people with ADHD in adulthood, they also have other psychiatric conditions. And so they can present with depression, bipolar, and anxiety. So in this study, again, it's the Amsterdam study, in patients over the age of 50 with ADHD, about 40% had depression, about 25% had bipolar disorder, which is a fairly substantial coexisting prevalence rate, and the anxiety about 20%. 75% of these adults were also on other medication. And this becomes the additional medical challenge, not only in diagnosing, but in treating these patients with medication, because the average number of medications in an adult age 60 is 6. And so you need a lot of medical information to understand how to choose the ADHD medication, what drug interactions might be considered, and how to navigate all of that while explaining to the patient potential side effects. Medical illness, again, this is an older population, so hypertension can be an issue, thyroidism, diabetes. Cardiac issues is a particular challenge. One needs to be very familiar with how to prescribe stimulant medications in cardiac patients. I have patients who are post-MI, post-stents. They have arrhythmias, patent ductus ovale, electrical abnormalities. And I work with very good cardiologists at Hopkins in Baltimore, and they're very mindful about this. But the cardiac issues have not been an absolute contraindication. So don't let that be the obstacle to treating these patients, especially if you're a physician. You'll understand how to navigate through this. Seizure disorders, it has historically been said that stimulant medications will increase seizure potential. That actually has been disproven over the past 5 years. Post-stroke, you want to manage hypertension and track blood pressure and pulse regularly. Also assess for caffeine, alcohol, illicit drugs, and tobacco. All of these can have interactions with stimulant medications. Usually I tell people to stop their caffeine, go to decaf coffee or cola as I put them on their ADHD medications. And drug-drug interactions, I regularly assess for what are you taking over the counter. So many people now are taking supplements, vitamins, herbs, and some of these have deleterious interactions with stimulant medications. So do that assessment up front. Patients often don't tell us what they're taking over the counter unless specifically asked. Okay, so I get it, Dr. Goodman. We should be assessing for ADHD in older adults. I get an idea of what I should be looking for, how it presents, but does it really affect daily functioning? So here's a study. It's a small study looking at functional impairment. 24 adults between the ages of 60 and 77 who were self-reported for having ADHD. They also had a psychiatric comorbidity 63% of the time. But these folks said that their ADHD had a significant financial impact, 63% of those, and 71% of the 24 adults said it had a significant social impact. There's a small Israeli study with about 12 or 13 ADHD adults, older adults over the age of 60, and 45% said that they thought their ADHD moderately affected their day-to-day function. 27% said it severely affected their day-to-day function. A lot of people have said to me, look, it's how big a deal could it be if you're retired and you don't have much to do older in life? Well, talk to somebody who's retired, and what they'll tell you is it's a full-time job managing the Medicare statements, managing their medications, managing their taxes, their money, their finances, their bills. There's actually a lot to keep track of. And if you have ADHD, you typically pay bills late, you lose track of the money, you may find yourself getting into debt excessively. So it's not a walk in the park, even if you're 65 years old with ADHD. So that's all great. But does treatment work? And is it safe? You're talking about older adults. So there is only one international ADHD adult treatment guideline that cites older adults specifically. And I was actually invited to write this section for CADRA, which is the Canadian ADHD Resource Alliance. This was just published in the last few months. And in this guideline, we stipulated that ADHD is a real condition in older adults. We highlight the fact that ADHD should be part of the evaluation for cognitive complaints in older adults, that medications and psychotherapy are effective treatments, and I'll show you some information on that. Consider medical illnesses and drug interactions that we just mentioned, and also consider the fact that the patient can have both ADHD and a decline in their cognition as a function of age. Being able to separate out age-related cognitive decline from ADHD is really a conundrum because it often looks the same. But an experienced clinician will be able to say what symptoms seem to be much more a function of ADHD and what symptoms are a function of age-related. In other words, some people will say, well, my symptoms are worse in the last 2 or 3 years. ADHD doesn't get worse. And so if it's worse, it may be that they have age-related cognitive decline or what's called mild cognitive impairment plus ADHD. Until you treat the ADHD, you won't know what the residual age-related cognitive changes are. Now, there's no specific medication indicated for ADHD in adults over the age of 65. Why is that? Because the research trials excluded patients over the age of 65. And in fact, one trial, lisdexamfetamine, which is 5-hence, actually included subjects over the age of 50. And why were these subjects excluded? Well, they were excluded because at that time, 15 years ago, we were concerned about what effects it would have on these folks, and we didn't want to place the subjects at risk for unnecessary side effects. I was actually a principal investigator in the adult trials with several of these medications. Medicare also becomes an issue because these drugs are not approved. They can be considered experimental by definition, and then Medicare can push back. So often the approval by Medicare will largely be based on what the cost is of these different medications. But I have many patients on Medicare who are on these medications, and we managed to find something that is helpful and affordable for them. You need to measure blood pressure and pulse and side effects on a regular basis. Document that in the chart. Also, risks associated with existing medical illnesses like hypertension, cardiac illness, drug interactions, ongoing substance and alcohol abuse, which can contribute to ongoing cognitive problems. And so we really do try to get people off their substances and reduce the alcohol to maybe 1 drink a day. Dental procedures, surgical procedures, the anesthesiologist needs to be consulted concerning the stimulant medication and when to stop. That often has not been an issue. So what about treatment? And I'm going to walk through this quickly. There are some studies that have looked at treatment, and they've looked at the adults who have been on medication. In this study, again, it's out of Amsterdam. They do great research. It's 150 adults. And of those on medication, 64% reported that they were still staying on their medication. A quarter of them had said they had stopped their medication. We don't know why. And 23% said that they were not on medication. 35% actually were in therapy, specifically for ADHD. Of those who were on medication, 82% were on methylphenidate, 10% were on amphetamine. Now, before you come to the conclusion that methylphenidate must work better than amphetamines in older adults, you need to know that this is a European study. And in Europe, 90% of the stimulant prescriptions are methylphenidate. A, because that's what they train on, and B, they have a historical prejudice against amphetamine. So do not presume here that one compound is better than the other. In the United States, in fact, amphetamines are much more widely prescribed for adults than they are for children. And then 5% were on non-stimulant medication. The other interesting aspect of this is that of the medications for ADHD prescribed, about 60% were being prescribed by a family doctor, and 36% were being prescribed by a psychiatrist. And you might say, okay, well, that's Europe. How does that compare, or that's Amsterdam, how does that compare to the United States? 65% of all stimulant medications in the United States are written by primary care physicians. Now, that number changed somewhere around 2008, 2009. Before that, the bulk of stimulant medications were written by child psychiatrists, family docs, and child psychiatrists. So as mental health moves out of the mental health clinician's office and into the primary care doc, they are being asked more and more to treat ADHD with these medications. So are they better? Well, patients who are on medication say their attention is better than the non-medicated individuals. They have a better ability to manage their daily demands versus individuals who had stopped their medication. That there was, if you use extended release methylphenidate, it predicted longer duration of treatment. That is, patients stayed on the medication with extended release much more than they would with immediate release. But individuals later in life tend not to respond as strongly to the medication. The degree to which they don't respond as strongly is questionable, since my patients seem to do quite well and they're happy with their treatment. But medication is not the end-all and be-all. This is a chart that I developed now 12 years ago. And the purpose of this is to understand where the impairments are and what psychotherapeutic techniques to apply. So the medication will reduce symptoms, but if you have impairments, then organizational techniques are important. If you have cognitive distortions in your thinking in regards to self-esteem, self-critical, and catastrophizing the future, then cognitive therapy is important. If you have behavioral avoidance, especially with social anxiety, that you're less and less inclined to be around people because you can't remember the conversation or you intrude or interrupt, then behavioral and exposure therapy is important. And some are just life skills. How do you interact and navigate the world? So a therapist can very specifically identify where the deficits are and then utilize a specific form of therapy to be much more effective in treatment. So what did we all learn? Hopefully a lot. The takeaway points here: screening for ADHD is an important assessment in cognitive complaints, especially in older adults. The cognitive complaints in older adults should not be easily discounted as age-related decline and miss the opportunity to treat this person. Consider medical etiologies of cognitive complaints so that you don't spuriously make a diagnosis in error of ADHD and put somebody on medication they shouldn't otherwise be on. The impairments of ADHD persist into adulthood, and that ADHD treatments are effective for older adults just as they are for younger adults. It used to be said that you don't lose your ADHD because your pediatrician discharged you, and you don't lose your ADHD when you get your ARP card or your Medicare card. So it's never too late to treat people. One of the reasons it's never too late is that if you spent your whole life with a disorder that you thought was a function of you, that you're lazy, that you're stupid, that you're incompetent, that you're not capable, and someone comes along one day and says, you know, you have a treatable condition. Let me show you how much better you can function. Even at 80, and I have a patient in her early 80s, even in 80s, it's a liberating experience. Why? Because the person comes to understand that what they believed was them was a treatable disorder. And part of the psychotherapy, especially for older adults, but everyone with ADHD, is to teach patients what they have, the disorder, versus who they are as a person. And that is very invigorating and helps people resurrect their self-esteem, having grown up in an environment telling them that they were simply incompetent and couldn't amount to very much. And so with that, I'm going to end, and I do look forward to your questions. I appreciate your attention, and hopefully your time was well served here. Wayne, I'll turn it back to you.
Yeah, I have plenty of questions. That was a great presentation. Really fantastic. Lots of questions about, is there any knowledge or research about the effect of menopause on adult ADHD?
The short answer to that question is no. We do not have any information. I don't know of any research that's been published in this area. And for my junior academic colleagues, if you want a career, this is a fertile ground for research. There are research studies looking at the change in cognition with hormone changes in menopause. And so I know some people have said that ADHD seems to get worse during menopause, but I'm not sure it's ADHD getting worse or whether the cognitive symptoms as a function of hormonal changes get worse. And I know that that's a hair-splitting distinction, but it's a distinction made because the neuroscience etiology might be different, and because it's different, the use of medication and the research focus might be different as well. So for the average person on the street, I would say if you have ADHD and you're going through menopause, your cognitive ability is probably going to be worse. So would that translate into a change in treatment? In other words, okay, well, I was on X milligrams of stimulant medication when I was 45, but now that I'm 53 and going through menopause, should I increase my dose? I don't know the answer to that question, and there's not a single published research trial that would answer that. Clinically, I might suggest going up and seeing if there's benefit, but I also refer patients in that situation to their GYN to reconsider whether or not hormone replacement therapy would be helpful. And in that situation, the hormone replacement therapy complementing the ADHD medication has been helpful.
Do the symptoms of ADHD get worse in seniors? This man writes in, I am 59 years old, diagnosed at 40, and it seems in the past couple of years things have gotten worse, particularly the emotional elements. I can't seem to control my emotions as well as I once did, and I've also become more forgetful. So that's the question. But I thought in your presentation you said that the ADHD doesn't get worse as the senior years go on, or am I got that wrong?
No, you got that right. So let me expand it a little bit more. ADHD symptoms over time don't get worse. What might change is the experience of the ADHD, and they may seem worse if the environmental demands increase. So in that kind of situation, you might increase medication in order to overcome that and or augment with organizational skills. For the gentleman who asked the question, though, I would say, as many of my older patients have said, yes, I was diagnosed with ADHD as a child or in my 20s, but the symptoms have gotten worse, and I'm now in my mid to late 50s, early 60s. To that regard, I would say you've got two possible components, the ADHD and age-related cognitive decline. The way you separate this out a little bit is by altering the dose of the stimulant medication. But to be even more specific, age-related cognitive decline usually shows up as more forgetful. Now, you can say, well, forgetfulness is part of ADHD. But if you've been on medication and your forgetfulness now is worse over the last 2 or 3 years at this age, I might say that this has to do with an age-related change. The other aspects of age-related change are name-finding difficulty, stumbling over spelling of words that previously brought no problem to you. And there's a few other subtle differences. The next question I would ask, anticipating, well, are there any neuropsychological tests that would help differentiate ADHD from age-related cognitive decline? And the answer to that is, I don't think so. And I've looked at this and talked to my colleagues who are neuropsychologists, and they've kind of shrugged their shoulders and said, no, that's an interesting question. I don't know if we have any research on it. So you don't necessarily want to go see a neuropsychologist to make this distinction. And a good clinician who has a lot of experience in this area can probably sort this out clinically by asking you the right questions. The emotional aspect is interesting, usually not a function of age-related cognitive change. So I would want to take more of a look as to what's going on. That is the history of the emotional regulation, the periodicity of it, and if any medications in the past have been useful.
Mm-hmm. Another person asked, is it difficult convincing someone in their 70s that they have ADHD when perhaps the behaviors were just the person thinking he's always been him or herself, it's just him or her? Is there a lot of denial? Do you happen to run into that with older patients?
Right. I mean, the answer to that is pretty clear. It is hard to get people to appreciate they have symptoms of a disorder when they've incorporated all of that into their self-image. What breaks that down then is usually their child, an adult, gets diagnosed. So let's say the grandchild at 12 years old gets diagnosed, then mom goes in, she gets diagnosed, and then mom turns to her mom and says, you've always been this way. And so there's a series of conversations over time. As the older patient, the grandmother, watches her daughter improve in her level of function, she may start to say, maybe I should take a look at this since you've been doing so much better. And that's generally how the older folks come in to see me, because their adult children turn to them and say, you know what, this has been running in the family, and I think we all got it from you. But it does take time to talk to these folks. And other people will say, look, I'm 70 years old. I lived my whole life this way. Well, why are you bothering me like this? And when I have patients who come in at that age and they say, look, I'm not here because I want to be. I'm here to satisfy my kid. And they said I should come in and talk to you about this. And if they do have a diagnosis of ADHD, I say, look, I know you've spent your whole life like this and you've grown accustomed to it. But, I think you have a condition that I can treat and you can be better in a few days. Why don't we try to do this for a month? At the end of the month, if you like the outcome, then we'll have a discussion as to whether or not you want to stay on the medicine or stay in treatment, in psychotherapy. And if you don't like the medicine, then you throw the medicine away and you go back to how you were. If they have ADHD, they're going to likely respond remarkably to the medication. And I'm not saying that psychotherapy is secondary, but psychotherapy's effect takes time. Medication's effect take the day you take it, the next day you take it. And often, once you induce that change and the person has that experience, then it becomes up to them as to what state of mind you want to live in. Do you want to live in a state of mind you're familiar with but are compromised? Or do you want to live in a state of mind that, wow, the fog is blown away and you're able to do so much more? That's the point. I don't tell people you need to be on medication for the rest of your life. Every day in the morning, if you've ever taken medication, you take the medicine because you believe the quality of your life is better on the medicine than off the medicine. And at such time where the quality of life is not affected by the medicine, that's when people stop taking medicine. So it's an empiric trial for the older adults, and more often than not, they say, wow, I had no idea this is the way the rest of the world functions.
That's a good answer. This man has been diagnosed at 55. He's taking Adderall. His dad, it sounds like he thinks his dad has ADD and wants his doctor to give him Adderall as well. He says, I realize that you don't have his full medical history and there might be other issues, but my dad reports that the doctor said it was not based, that he wouldn't give him medication and it wasn't based on his specific medical history. The doctor just won't do it. In general, is this an uninformed doctor or is this common? I guess we're talking about prescribing medications to very seniors. So I guess that's what he once answered.
So you said, is this an uninformed physician and is it common?
Yeah.
And I say the answer is both. Those of you who are listening to this presentation, you're hearing a presentation that's quite frankly hard to come by. I do this presentation periodically for a room full of several hundreds of clinicians. But for every clinician I speak to, there's 1,000 clinicians who've never heard this. And so the older clinicians have trepidation about prescribing stimulants because we grew up in the age where stimulants were an absolute no-no. They were highly addictive. They didn't work for obesity, which is why they fell out of favor. They caused all kinds of psychiatric problems and cardiac problems. And that was in the absence of data. It was reasonable to assume that they were high-risk medications and we shouldn't prescribe them. But it turns out with the evolving research in the last 5 years, that's just not the case. And that even older patients who truly have ADHD and benefit from the medication can be on these medications as long as the physician is mindful. And it should be a medically trained individual, whether it's a physician, a nurse practitioner, a physician's assistant, a specialty nurse. But you need medical information in order to track patients, their blood pressures, their pulses. If you need to do an EKG, if they've had cardiac illness, then you coordinate with the cardiologist or the internist or the family practice doc. But I understand why clinicians and physicians have concerns about prescribing, and it just means gathering more information in order to substantiate the diagnosis. And then seeing whether the physician has flexibility in learning about this and taking a trial, starting at a low dose and seeing what the outcome is.
Mm-hmm. As an adult diagnosed in my 60s, 2.5 years into treatment, less than optimal medication, I am now looking to Medicare to cover costs. What recommendations might you have to assist in navigating continued challenges of ADHD?
So you want to coordinate this with the prescriber. I think that they will approve, and I'm going to use brand names just because it's easier, not because it's promotional in any way. Adderall XR comes as a generic. I think Medicare doesn't have an issue with that. Concerta comes as a generic, so they likely won't have issues with that. Some of the newer long-acting stimulant medications are probably more expensive, and Medicare has you jump through hoops. On occasion, where cost really becomes an issue, the immediate release stimulant medications like methylphenidate or amphetamine will be approved. You often have to take those medicines at least twice, if not 3 times a day, so it becomes a bit of an inconvenience to take it that often. But you should be able to find some stimulant medication. The other option is considering atomoxetine. Now, I don't know of any literature on atomoxetine in older adults. So I don't know if it works. I don't know if it doesn't work. I don't know what the potential side effects are. But that would be an option as well. Atomoxetine, which is Strattera, also comes as a generic. So there are options. It requires working with somebody who really knows all of these different medications and what Medicare will agree to. Generally, mm-hmm. Medicare will agree to something that's cost effective for them.
Mm-hmm. Can sleep disorders worsen ADHD symptoms with age?
Great question, because sleep disorders are associated with ADHD in the another study out of Amsterdam. Great people over there. 40% of ADHD individuals have a second sleep disorder. So many of these folks have difficulty falling asleep. My experience has been that those are the same people who, as children, had difficulty falling asleep. So we want to differentiate sleep difficulties as a function of ADHD versus sleep disorders that are independent. So what would that be? Sleep apnea comes to mind. So I routinely inquire about snoring and energy level during the day in order to rule out sleep apnea. We often associate sleep apnea with obesity, and that's called obstructive sleep apnea. There's also central sleep apnea, which is sleep apnea arises from brain circuits and has nothing to do with how large or small you are. So I tend to speak in paragraphs. I'm sorry. The short answer is yes. Assess for sleep apnea. Cognitive complaints can arise from sleep apnea. If you have sleep apnea and ADHD, it's possible that your cognitive symptoms are going to be worse. And I will regularly send people for sleep studies and get them on CPAP just to see how much more improvement. And we can do that concurrently. So you can be on a long-acting stimulant ADHD medication and use your CPAP for sleep apnea. And sleep apnea also tends to run in families.
Oh, I didn't know that. Oh, okay.
Yes. So some sleep apnea is genetic, and some sleep apnea is a function of obesity.
Mm-hmm. This is a basic question, and it comes from the patient end of the spectrum, not the clinician. How should a person over 50 get diagnosed? She suspects she has ADHD. Where should she start?
So this is a great question because it's like standing in a desert and saying, where do you think the closest water fountain is? If you believe you have ADHD, here's my recommendation. First, do a little research so that you understand what ADHD is and how it gets diagnosed. Then pull one of the rating scales for adult ADHD off the internet. So this is widely available. If you go to our site at www.addadult.com, there is a 18-item adult self-report scale. Now, this is the self-report scale that was validated, standardized, and is used by the World Health Organization. And on that, it's scored on a basis of frequency. It's the 18 symptoms of ADHD. And sit down and score it and see what your symptoms are. Then, though, what you need is to score those symptoms based on your recollection as a child. So think about sitting in class, sitting in lectures, doing your homework assignment in grades 5, 6, and 7. Then see if you can talk to family members and see if there's any immediate family members who have been diagnosed with ADHD. Now, armed with that information, you go in and talk to your physician. If you feel comfortable, go into the primary care doc. But then you want to lay this information out. You want to make it as easy as possible for the physician to come to the conclusion that, yes, this looks like it's substantial. If you make the clinician work to make the diagnosis and they're not familiar with how to make the diagnosis, you're going to be dismissed. If you go to a website, and I have no relationship with this website at all, the website is called... if you go to Attitude Magazine, do you have a directory of clinicians? Now, you may have a directory of clinicians who are not medical, but those folks typically will have a relationship with a physician that they refer to, and that physician might be familiar enough with ADHD that they can feel comfortable doing this. If you live in an area where there's a major medical center, call up the Department of Psychology or Psychiatry and ask if they refer out to someone in the community who treats ADHD in older adults. But having said all of that, it is going to be a bit of a challenge to find somebody who has expertise in this. Please understand, I was invited by Wayne to give this webinar because there are just too few clinicians who know much about this. So don't be surprised if you run into clinicians who shrug their shoulders and say, I'm not going to prescribe that to you.
I think that'll have to be the last question, David. We're just about out of time. Great insights and strategies, really a ton of expertise on how to handle all of this. So I want to thank you again for being here.
I appreciate your inviting me, Wayne. Thank you.
And for everyone, you can reach David at addadult.com. ADD Adult. That's singular, no S. And have a good day, everyone.
For more Attitude Podcast and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.